Hi all, welcome to this NHS Confed briefing today. I was about to say this morning, and we've just passed midday. So if I can just start by saying this is going to be recorded. So if people don't want to see their faces on the recording, could you switch your cameras off and also stay on mute whilst the session is in progress, unless you're going to chat and ask a question. I'm Gary Senti. I'm VCSE Programme Director, and I'm from the Humber and North Yorkshire Health and Care Partnership. I've been asked to chair this session today and take us through the next hour and a half. Fortunately, I think I've got the easy job of just keeping us going and keeping us moving through this session, but we do have three systems here who are going to share their work with us today, and we will go through them in turn. But we've got colleagues from Hampshire and the Isle of Wight, Hertfordshire and West Essex and Gloucestershire, who are all going to share some of their work. I'm going to ask the speakers to introduce themselves as and when they come up to present their work, but we thank them all for contributing to today's session. I'm sure it's going to be very valuable for us all. In terms of the session today, why we've been brought together, everyone I'm sure will have seen NHS England guidance that came out in April that basically said ICPs, integrated care partnerships and integrated care boards should have developed a formal agreement between the VCSE sector and the ICB, a formal agreement to engage and embed the sector into system level governance, decision making, and ideally that's through working through the VCSE alliance or alliances at place. This webinar recognises the importance of the governance and decision making and the partnerships to be in place between NHS and VCSE. And fundamentally, it's about the difference this way of working can have and makes for patients and people on the ground, and the impact the sector can have on health and well-being. And that's what our speakers are going to share through some of their work today. So we're going to have three speakers that are going to come up. They're going to present for about 20 minutes each. There will be time at the end of each of their presentations for any burning questions that need to be answered there and then. Otherwise, we will have some time towards the back end of today's session where we will have a Q&A session with the panel, which I will take us through at that point. It's good to see that people have already started to introduce themselves in the chat, but if you haven't already, if I could ask you to put your kind of name, role, where you're from, that would be fantastic, so we can see who's here and whereabouts across the country. I think that's everything from me to start off with, so I'm going to come to Gloucestershire first, and if I can ask Matt to unmute himself and any other colleagues that are presenting as well, and the floor is yours for the next 20 minutes.
Thanks very much, Gary, and thanks for having us. We really appreciate having all these eyeballs on Gloucestershire. We're really proud of the work that we're doing locally. We think that we've achieved a huge amount in the short time that we've been working on this project. And me and my colleague Jill Parker are going to talk through some of that today. I'm just going to try and share my screen. So there's two bits to our presentation today. The first bit is from me, and I'm going to talk about the state of the local voluntary and community sector. Gary, can I just check you can see my screen?
I can, yeah, it's all good.
Wonderful. So I'm going to talk about the state of the local voluntary sector in Gloucestershire, and Jill's going to talk about the MOU, the mechanics, the governance about embedding the voluntary and community sector into the ICB system. So we're quite fortunate in Gloucestershire because we've had a VCS alliance for about 7 years now. So when the NHS guidance hit in April, we were absolutely delighted to see the reliance on the VCS because we felt that we could really hit the ground running, and in many respects we absolutely have. So Jill was going to go through that part of it, but what I wanted to start with is where the sector currently is, and this may feel like a bit of a curveball to folks, but the sector in its components and its challenges and its origins and the way that it's working is incredibly important to the future relationship that it has with the NHS. And the information that I'm about to present probably isn't what we expected to see locally, and it might not be what you expected to see either. So although it might feel like a bit of a curveball, we think it's highly relevant to the future working relationship with the NHS. So this is the first bit of data I'll share. So there's 5 slides that I'm going to share with all kinds of data about the voluntary community sector on it. The first one is this, which is the headline to say 38% growth in income generated by charities in Gloucestershire since 2019. Now, this is completely against what we were predicting at the start of the pandemic. We were expecting to see many charities fall over, a huge amount of them make redundancies, and we haven't seen anything like that locally whatsoever. Growth is really difficult to come by, and the voluntary and community sector is achieving it in spades. So in isolation, that statistic is incredibly amazing and not what we expected to see whatsoever. However, being a slight pessimist at heart, I always look at the so what and the why. And I think that the why is quite clear. This is directly linked to COVID grants that have been pumped into the VCS as a system. And that has been great in terms of keeping organisations afloat and to try and keep up with demand. But what it hasn't done is kept up with that demand, because actually what we're seeing, particularly with mental health providers locally, is about a 66% increase in voluntary sector demand. So the 38% is fantastic, but it's not keeping in demand. And those that don't know Gloucestershire particularly well, there are areas of affluence within Gloucestershire, and there are areas of poverty within Gloucestershire. And looking at the core 20+5 model that our NHS are currently using, most of those areas are in Gloucester City. And there's only an 8% increase in the turnover in Gloucester City and a 56% in Cheltenham, which is a particularly affluent area, 45% increase in Cotswolds, which again is a particularly affluent area. So although the 38% income isn't what we were expecting to see, it's not tracking with demand, and it isn't being put in the areas that we'd expect it to be put. The next slide is income by district and the population size. So across Gloucestershire, we've got 6 districts. All of them have a similar size population. However, what they do not have is a similarly well-resourced voluntary and community sector. So in Cheltenham and Cotswold district, the spend per charity per capita is between £2,000 and £3,000. In Tewkesbury, it's £300. So what we can see here is very much a have and have not of investment in our local voluntary sector, which is quite stark and quite difficult. And the reason I included this slide is because it shows the willingness of organisations based in these different districts to engage with the NHS and their activity. The third slide is around the sector's growth in terms of the numbers of charities that are operating within Gloucestershire. For me, this is a real stark bit of data. So there's 229 new charities now operating in our county. So that takes the number to 2,512 bona fide registered with the Charity Commission charities that are operating, which as a headline is really positive, because we expected a lot of them to go to the wall during the pandemic, and that hasn't happened. And in isolation, again, that is an incredible stat. However, when we did the State of the Sector report in 2019, the 3 areas that charities were telling us they were really struggling with was recruitment of trustees, recruitment of volunteers, funding and the competitive nature of commissioning, and also the increased competition around relevance for charities that were operating in our county. 10% increase in that makes it 10% more difficult. So particularly within Cotswold district, we've seen 71 new charities, Stroud 84 new charities that are registered. We have to look into why this is happening. We suspect that it's a lot of small unincorporated organisations that have got charity status so that they can access funding. But this, although it's impressive that there are more charities that are operating in the sector, it also makes things a lot tougher for organisations that are currently operating in that space. This is the sort of financial makeup of charities that are operating within our county. And I'm not surprised to see the micro or the small or indeed the large. What I was surprised by, and it has changed quite dramatically since 2019, is the medium-sized charities. So those operating in that space of 100,000 to £1 million. What we are looking at as a VCS Alliance now is affiliate models, mergers potentially, because we want to ensure that the best bits of charities are maintained and can continue going forward. And we think that most of those that you can kind of hang your hat on if you're a small organisation are going to be in that medium bracket. And so there probably isn't enough infrastructure within our county to achieve that. And just going back, one of the problems with having so many charities in the county is the number of databases and IT services and trustees and bureaucracy that has to be related to those charitable organisations. What we don't want is the number of charities. We can't use that as a metric for success in and of itself. It's about demand and whether we can cater for that demand. And then finally, from me, it's the reserve. So ever since we've been doing the state of the sector data, the reserve levels of charities held by Gloucestershire has tracked almost identically with the income. Now, this year, there's £650 million worth of income and only £600 million worth of reserves. So that's gone down significantly. And within Cheltenham and Gloucester, that's where the bigger charities tend to reside. And to see a 20% decrease in the reserves from Cheltenham and 34% from Gloucester City is really worrying. And I think that to me is the first signs that everything is not quite all well within the charity sector. So just to conclude, and then I'll pass over to Jill to talk about the governance and the MOU stuff, that the growth is impressive. To achieve any growth in today's market is impressive, but also directly linked to COVID, so maybe artificial. The growth isn't in line with demand anyway, because we're seeing greater demand for services than 38%. The growth isn't where we anticipated it would be based on areas of deprivation within our county. The sector may be too big. It's difficult working with, there's 5,500 VCS organisations in total in Gloucestershire, but working with 2,500 charities is difficult, particularly when you're trying to be a voice organisation and embed them into a wider system. Mm-hmm. And that the growth, although impressive, it doesn't make those core issues go away about competition for relevance, competition for trustees, for volunteers and for funding. So Jill, I'll hand over to you.
That's great, thank you. So I'm Jill Parker and I'm Head of Operations for Gloucestershire VCS Alliance. So the bulk of my role is around building the relationship between the voluntary sector and the various organisations that make up the ICS. And Matt's explained some of the work we've done on understanding the VCSE sector in Gloucestershire, and now I'm going to talk about how we're putting structures in place to develop a meaningful partnership with the integrated care system. So next slide, please, Matt. So this is vital because we know that things like lifestyle, income, education, employment, where people live, have a much greater impact on people's health and well-being than their engagement with the NHS. And many of these social and environmental factors are addressed by the voluntary and community sector. In Gloucestershire, the geographical boundaries of our ICS are the same as the county boundaries, so this makes things relatively simple for us. We have one ICS, which is called One Gloucestershire. We have one county council and 6 district councils. And within the ICS, we have 6 integrated locality partnerships, which are co-terminus with the district councils, and they're responsible for shaping services at a local level. So they've been running for a while, but I would say that they are still embryonic in terms of their impact, but they do have a high profile within the ICS, and it's intended that they'll become significant budget holders. So next slide, please. So the changes and the new structures present us, the voluntary and community sector, with some significant opportunities. I'd say the first of those is about having greater influence regarding the health and wellbeing agenda in the county. Secondly, I'd say it's an opportunity to reset the relationship between the VCSE sector and the public sector, from one which we sometimes describe in terms of a power imbalance to a more adult-adult relationship. And potentially there's a third opportunity, which is to draw more funding into the sector to support more people in our communities. And obviously this is all happening within the context that resources are very tight and there are no promises of new money attached to the changes. However, if the NHS is asking us to do more as a sector and is committed to full cost recovery, which it says it is, then logic tells us that funding must follow. Next slide, please. So as a VCSE sector, we've been organising ourselves in response to these opportunities. So we've worked collectively and with our public sector colleagues on a memorandum of understanding between the sector and One Gloucestershire. So this work has been supported by a series of workshops which has engaged a significant number of people from across both sectors. And I'd say the MOU is really meaningful to those people that have been engaged. So the MOU describes how we'll work together and the practical steps we'll take in the first year of its life. So some of those steps include a review of how the NHS commissions voluntary sector organisations, and this includes a commitment to proportionate commissioning processes and full cost recovery. It includes better use of voluntary sector data to inform decision making and more sharing of NHS data where that is possible. It includes the development of a social value policy for NHS organisations in Gloucestershire. So collectively, these organisations have a huge workforce and huge spending power. So the potential of directing all this resource in a more socially responsible way is enormous. And finally, it includes funding for voluntary sector representation to support engagement with the public sector. Next slide, please. So we are developing our own structures for leadership and representation. And we've recently developed a VCSE strategic partnership. So this is an elected group of leaders who have a mandate to oversee the implementation of the Memorandum of Understanding and to provide overall strategic direction of sector engagement with One Gloucestershire. When we were kind of going through the process of how do we choose people, I kind of talked to peers around the country who all kind of said that in their area they were developing a leadership group, but it was a kind of coalition of the willing, and we just felt really strongly that what we wanted was an elected group of people who have a legitimacy and a mandate to speak on behalf of the sector, and that's really kind of bearing dividends already, that those people have a respect and a legitimacy that maybe wouldn't be there if they'd kind of just been viewed as the people who kind of always get involved in everything. So
yeah, I'm not sure whether we have lost Jill and her connection. Matt, I don't know whether you're able to pick up the final few slides.
I think I am. Okay, so this is the ICB's draft plan on a page, essentially looking at what's going to make Gloucestershire a better place for the future. What do we need to transform what we're doing currently? And what's the health and care sector, what's it going to look like today? So what's the immediate priorities, what's the long-term vision, and how do we get there? That we're currently co-producing this with the ICB, and this is in draft at the moment. We will go into its sort of real format at the start of next year. The VCS has been an absolutely integral part of creating this document, and we've got our own bit of the plan, which is going to just slide in very nicely, but also peppered throughout the document is the relationship that we want to see with the ICB and with the voluntary community sector. It's been a long old journey for the last year or so, but one that is already paying dividends. The VCS feel really an integral part of everything health and care. They feel like a strategic partner rather than a delivery partner. We've really challenged that sort of parent-child relationship that used to happen between commissioners and the voluntary sector, and really starting to make inroads at a strategic level. So we're delighted with the work that's happening in Gloucestershire, and long may it continue.
Okay, thank you for that, Matt and Jill. That was really useful to see how it's developing, and I can certainly resonate from a Humber and North Yorkshire point of view. There's many similar conversations going on with the system, and certainly seeing some of the similar thoughts in terms of the sector. I think it's great that we saw the growth of the sector. I think that needs to translate into resilience of the sector, which has clearly happened during the pandemic. I feel it's about to be tested again as we go through the cost of living crisis, but we'll see how the sector and the system work together. So we do have a couple of minutes. If there's anybody who's got any specific questions for Matt and wants to raise your hand now, you can do. Like I say, we do have the panel discussion as well coming up. I think we've got Jill back with us as well. Welcome back, Jill. So any questions? I see one hand. So Lee, do you want to come in, please?
Hi, I just wanted to explore the charitable income slide. It doesn't seem to be differentiated between contracted income and income generated by other means. And I just wondered, has that been done? And promote the value of doing that to demonstrate the additionality that charities bring.
So thanks for the question, Lee. It doesn't differentiate it on the slide at all. We are doing some work internally to make that difference, because it clearly is a really important bit of the picture. This is just the headline data at the moment. So we're doing more work to explore specifically that kind of level of detail, but it does take quite a lot of time and effort. We're prepared to put the legwork into it, but we haven't got it currently.
Thank you for that. We've got 3 hands up, so I'm going to take those 3 questions and then we will move on, and any other questions can be answered in the panel. So apologies, I don't know your name, but Community Links Bromley.
I'm Christopher. Just in terms of what's the relationship between place, strategic, the strategic level, and neighbourhood? How does that look like? I know you alluded to in the slides about the was it 40-odd% micro organisation. So what does that look like in practice? What's happening with those relationships?
So what we've done is each of the integrated locality partnerships within Gloucestershire has 2 VCS reps, specifically nominated, voted in reps. And what we have done as a VCS Alliance is to wrap a forum around those representatives so that people at a neighbourhood level can get engaged directly with their ILP through those representatives. It's quite cumbersome, it's quite labour intensive, but to get that community voice, that neighbourhood voice into the ILPs to support the strategic decision making, we can't think of another way of doing it, a quicker fire way of doing it. So it's about creating those specific forums, getting representatives from the ILPs to come out to those forums and then feed those conversations in.
We've also made sure that at least one of the reps on each of the ILPs is from a small or micro organisation, so that perspective is voiced within the system.
Yeah, thank you. I think that's really important, that diversity across the system. Come to Julie and then Francis after that.
Thank you. Really interesting presentation, and great that you've got both small and larger organisation in your representation model. And my question goes back to the bit that you said revolving around proportionate, commissioning, full cost recovery, and your social value policy. And you talk about it just in a health perspective. Does that cross over into social care and your work with councils? Because from my perspective in Cambridgeshire, we have some of it happening with our local authorities and some of it happening with our health colleagues, but it doesn't necessarily connect in the right place. Have you managed to crack that one?
I suppose partly is the answer to that question. I don't want to be rude to our colleagues in the local authority, but we find probably the NHS an easier beast to work with currently. There are bits of our local authority that are part of the ICB, see themselves as a part of it because they're delivering on health inequalities. There are parts of it that absolutely don't see our MAU as being something that they are adhering to whatsoever, particularly things like transport. But we're kind of moving into that space more and more. I suppose what I'd say is we've gone where the energy is, which might not have been the best approach, but we needed to start somewhere and create something. So parts of it, particularly public health within local authority, are totally engaged with what we are doing. There are big parts of it that are yet to be fully engaged in it, but they need to have ownership of it too. So, I mean, Jill mentioned this is a 12-month document. We will continue to review this and continue to sort of build the moss on the rock, if you like, as we go through more and more. So we've got the local authority and then we've got district councils. There's plenty of more work to do with the system to make sure that we've got a more robust, well-rounded MOU.
Perfect. Thank you for that. And final question to Francis before we move on.
Thanks, Gary, and thanks for that very interesting outline of your work in Gloucestershire. I was looking at the slide on the plan that's been produced, and you mentioned the sort of strategic involvement in that planning process. Have you felt there's been a difference in terms of how the VCSE sector has been involved in shaping that plan this year? You said it had been quite a long and tortuous process, I think, Matt, but has the involvement been more strategic and more influential this year through the kind of mechanisms and processes and alliance structure that you've set up than perhaps, the NHS does a lot of planning, doesn't it? Has it been a step change from previous experience of the sector?
Yeah, and part of the reason it's been tortuous for us is because we've changed the way that we work. So it used to be basically wheel me out to be a VCS rep, and to change that to say actually we need to have accountable representation within our voluntary sector to get the right person into the right part of the system at the right time. It's been a huge process for us and a complete change in the way that we've gone about doing business. But one thing that I've really taken to heart during this process is that we had about 60 organisations, a core group of organisations that have stuck with us on this journey throughout, all the way through, having quite embryonic and abstract conversations about what the ICB might look like, right through to the direct delivery and being representatives on the ILPs, all the way through the process. And that's been time that they've taken out of their own organisation to put into this agenda, which I think has been incredible. We've never done such a well-rounded and inclusive piece of work with the voluntary sector. I've never seen them more motivated to work on a strategic piece of work. And that's been all the way through the system, from small organisations right up to the big players that you'd expect to be there. So we're really proud of that. I think that's an achievement in itself.
Perfect.
Absolutely.
Thank you, Matt and Jill, for that presentation and for the questions as well. There might be a couple of specific questions in the chat box that you might want to respond to. And also there's been a couple of questions in the chat around the slides. If I can ask NHS Confed colleagues to just answer that one in terms of if, when and where the slides will be shared afterwards, that'd be fantastic. But I'm going to move us across now to Hertfordshire and West Essex. And if I could ask Tim and colleagues to unmute themselves and put the cameras on and take us through the next 20 minutes, that'd be great.
Hello, everyone. I'm Tim Adlergoff, Head of Community Resilience with the Herts and West Essex Integrated Care Board. Somewhere, Joe Marovich, who's the Chief Executive of Mind and also Chair of the Alliance in Herts and West Essex, may not be physically with us at this precise moment.
I am here.
because she's in the process of trying to replace the boiler that was stolen overnight. But anyway, we're going to talk you through, I'll do most of the talking and Jo will shout if there's something she particularly wants to raise, and then we'll answer questions later. Next slide, please. We wanted to focus, and Jill's already mentioned this, really excellent presentation from Gloucestershire, but why we're working with the voluntary sector at all is always, I think, worth thinking about, and that's why we've got various ways of looking at what actually creates health in the population. And as has already been mentioned, only 10 to 20% of it is anything the NHS does. And all the other areas are ones that local voluntary sector is likely to be key in either helping you access or providing themselves. Next slide, please. And in terms of everything that people need in their lives, despite the fact that so many people turn up at GPs or A&E because they don't know where else to go, actually medicine can't solve problems like not knowing why you should bother to get up in the morning. It can over pathologize human distress and prescribe medication for things that might be better dealt with in other ways. And the last quote there is from a CAB in Hertfordshire where, as you can see, someone was having to switch off their CPAP machine and not charge the mobility scooter, so at risk of well, dying actually, because they're worried about putting on their heating and so on. And the interventions there to get you what you're entitled to, plus a 40 quid goodwill voucher from the provider, and ongoing work to get a heating grant and so on. These are the things the voluntary sector do day in, day out, and are critical to people staying well and healthy, but they're often invisible to the NHS. Next slide, please. Although, to be fair, the Confed very clear back in August that the coming cost of living crisis was absolutely a humanitarian crisis. And indeed, we are, I think, predicting a 50% increase in admissions for respiratory this winter, which I presume is a mixture of COVID, but also very much people being afraid to turn on their heating and so on. And that's going to be a really big issue. Next slide, please. And just to labour the point a little bit more, these are CAB clients who have significant fuel debt or need for priority service registration. You can see that 10% of them are disabled, 54% of them have a long-term condition, and only 36% of them have neither. And you can see how big mental health is among that group of issues labelled as disability. And it's a really important reminder, I think, that people who rely on the NHS and social care need a huge amount of support in other places to get what it is that they need as well. Next slide, please. And then lastly, this is a guy we'll call David, and it's a classic social prescribing intervention, really. When the link worker visited him at home, they found all these issues around hoarding, stockpiling, rotting food, unusable bathroom and bedroom, no heating, no hot water. He was in debt, he was lonely, couldn't use his garden, and he was on the list to have a heart operation. Next slide, please. And what made the difference to his outcomes were all the work done by the voluntary sector. So in this case, I think this is quite a good example of the huge variety. CAB, the benefits advice, step change to get his debt restructured, Care for Freedom, which was a hoarding service. There was input from Hearts Healthy Homes. He was linked to a meal at Easter and the local CVS as well as church coffee group. And we're stressing the F in our VCSE because faith is so important in this. The Green Aid has cleared his garden, etc., etc. And as a result of all of that, his heart operation clearly is going to have a much better outcome than if we'd been blind to his social conditions. Next slide, please. So I think it's worth stressing all that, because although we're rightly talking about governance and the MOU and all the rest of it, it's really important that this stuff is about acknowledging how important the VCSE is, treating it as an equal partner has been mentioned, but an absolutely crucial part of the system as a whole. And that formal agreement, in our case, we haven't got that far yet. But what we have done is work together in co-producing a health creation strategy, which I'll come on to in just a minute. And then that will basically form the MOU alongside some other stuff about funding, etc. So really important that we are moving to this much more, I think the words grown up were used by Gloucestershire, I think it's a good word in terms of that relationship. Next slide, please. Excuse me. And yes, and stressing that the value of this work isn't just about that kind of clear partnership relationship. It's about so much of the health creation that the voluntary sector does is not seen. And if it is seen, it's seen by one bit of the public sector that is commissioning for one particular reason. And there's a real job of work to be done to get these different commissioners working together to integrate their thinking. In the real world also, people access the voluntary sector in a very haphazard way. We've done quite a lot of work over the last 10 years to reduce that randomness through having in Hertfordshire a single point of access to the voluntary sector called Heart's Help, and in West Essex one called the Essex Wellbeing Service. And that is reducing that randomness, and so is social prescribing, but there's still a long way to go. I spent about 30 years working with the voluntary sector in Hertfordshire, and if I had £1 for every time someone said, if only I'd known about this 5 years ago, Tim, when a really valuable local voluntary sector support was made available to them, I'd be a reasonably rich man. And I think it is incumbent on all of us to make sure that the whole system, and that includes the voluntary sector, is much more joined up than it's traditionally been, so that you feel less like a pinball going around the system and more like someone's being helped on their way and navigated through it. I think one of the things that is most important about the voluntary sector is it tends to have this zero tolerance of just leaving people floundering. And I think the statutory sector is much more able to say, well, that's not what we do, sorry. And what we're trying to do is create a system where all of that is joined together. So even if you go to the wrong bit of the system, which is a slightly odd way of looking at the world, but it's the way the system often does look at the world, you come through on the wrong number, all that kind of thing. It's about how we work together to say, well, we can't help you, but we always know that there's someone who can. And in our case, it might be Heart's Help, it might be social prescribing. We'll set you on the journey to find what you need, even if we can't help you. And we've got to make that easy, because the statutory sector is not alone, but it certainly feels very besieged at the moment by all the pressures on it. And if you're asking busy GPs, say, to understand a complex way of helping people access support in the voluntary sector, it's going to be really difficult to make that happen. Next slide, please. And one of my personal heroes, the great Professor Sir Michael Marmot, makes a very valid point about all of this, which is, what's the point of treating people? So going back to David with his heart problem, what's the point of treating him and then sending back into, a mess, which is just going to make him ill again? And though the NHS isn't going to be the thing that sorts all this out, its partnership with the voluntary sector is absolutely a crucial part of making sure that someone else is picking up on those issues. And I'm sorry we mentioned boilers, Joe, in the case study, because I know you just had yours stolen from your wellbeing centre last night. Next slide, please. So this is also why we've adopted the language of the Health Creation Alliance, because we know that the contribution that the VCFSE can make is very much around that sense of purpose, that feeling in control of your life, being in an environment where people are friendly. All these things are absolutely crucial. They're not part of the NHS's day-to-day business, but everyone in the NHS understands that these things are going to make people's lives better and their health outcomes will improve as a result. Next slide, please. So this is our Alliance steering group. As you can see, Joe is the chair. We've got 2 vice chairs. And interesting what Jill was saying about the credibility. We actually ended up with nominating half of the members on the board of 12, and the other half were elected. And we did this to build on the continuity of relationships at place. So where the voluntary sector was already actively engaged, talking with the statutory sector and commissioners. We wanted to build on that, but we also wanted to bring in people who weren't currently active and make sure that the sector itself was choosing those people. So it's a halfway house, but I think a really important one. And that committee will carry on until March 24, at which point we'll have another set of elections and it'll all be elected then. The other thing to say is obviously we're quite a new geography, with West Essex not feeling necessarily an obvious part of the ICS with Hertfordshire. We're building a culture around that, making that work, and so it's really important that the West Essex voluntary sector was really well represented on that board too. Is there anything else you want to say about that particular group of humans, Joe, or is that cover that bit? I mean, both health watches are there. We've got a CDS from each geography as well, with their role of making sure that the sector as a whole is.
They're all incredible humans, obviously. I would say that. I'll just note that we're at the beginning of that long journey that Matt described. I was quite envious that you've done this for 7 years, and I will definitely be getting in touch. But you know, we are on that journey. We're having a greater influence, I think, on the health and well-being agenda. We're involved in those discussions about the ICB strategy and the ICP strategy, and there's beginning to be a recognition that the voluntary sector is so embedded in the communities and connected with real people with real problems that actually we're well placed to address health inequalities, and I think we're showing that through our committee and in those meetings at the moment. And I would just say, sorry to interrupt him because I know you're going to carry on, that I think one of the main barriers for me is that there seems to be a fundamentally different culture and governance between the NHS, the voluntary sector, and local authority. And I think there's a piece of work to do about trust that we're heavily involved in our first year.
Thanks, Jo. Next slide, please. So this is just to show where we think this is all come together. So we haven't yet set up the health creation strategy group. We're in the process of doing so. And that feeds, as the strategy does, into the population outcomes and improvement committee, which obviously also focuses on health inequalities, and into the integrated care board. And it also feeds into, we have a strategic health inequalities board, which feeds into the ICP. So that's the link between all of this work, and the health creation strategy itself will form part of the integrated care strategy. And Jo sits on the ICB, and she and her vice chairs, so there's 3 of them, sit on the ICP. So we've got that all built in. And then, and as I mentioned, the health creation strategy is will form part of the integrated care strategy, which will get upgraded and revised every year. Next slide, please. So I'm not going to go through all of these 10, you'll be glad to see, but in terms of what's already been mentioned by Gloucestershire, I think it's really important, the bottom, number 10, about annual planning and reporting, about what the sector does, the difference it makes. We may well develop the work the CAB does around its public value model of showing its return on investment, and all the data about the huge amount that the sector does that often doesn't get seen except in small pockets. We'll be reporting on that annually. And then the other point I particularly wanted to bring out is the no wrong door policy. So going back to that whole issue of making sure you get to the right place at the right time, so that your journey doesn't become more complicated and end up in crisis, is absolutely fundamental to what we're trying to do as a system in partnership with the sector. Next slide, please. And I won't go through this in any detail, but I think it's helpful just to look at the way things link together. So bottom right, what you've got there is social prescribing has really, I think, helped us turn primary care from a sort of clinical island in the community, something which is much more joined up, whether it's reacting and then linking people into the voluntary sector, or actually reaching out to people it knows are at risk of, for example, not being able to turn on their heating or whatever, and helping them get the support they need. Bottom left, you've got the hospitals, which are obviously under vast pressure. There's an awful lot of work going on there by the voluntary sector, but it's often not really seen. it's not as integrated as it could be, and it's not as routinely excuse me, referred to as it should be. And that's a piece of work that we're linking together under the title of Better at Home, and we're really trying to build on. And then at the top, we've got the community, where there are all sorts of partnerships, very varied by place and by district, between different bits of the system, and making sure, again, that you're not stopped from finding that bit of support that's crucial to you staying well and healthy. And the role of Hearts Help and the Essex Wellbeing Service as the default. If you don't know where else to go, you can always go to them, and they'll help you find your way around the system. That's my 16 minutes. I'll just do the next 2 slides quickly, and I'll shut up. Next slide, please. This is a really important one. We're the second least deprived ICS in the country. And you can see the grey bars are the levels of deprivation. So we've got only about 3% in the most deprived quintile. But the orange bars are the Hearts Help clientele. And you can see that it's predominantly from the more deprived. And again, the blue are our main social prescribing provider, and they're mainly going the other way, so working most with the most deprived, which is exactly what we want to see. Next slide, please. This picks up the point really about always making sure that we're talking to the voluntary sector. So even if you're looking at the heart pathway, David, you should be thinking, is there a role for the VCFSE here? And if you're a consultant cardiologist, you probably won't think about it, but we need the system to be thinking, what if he's lonely? What if he's poor? What if he's got housing problems? Because they're all going to impact on how effective our treatment is. And then when we do think about the VCFSE, sometimes it's about as a provider, and we have to do that in the right way. Sometimes it's as a voice for the sector, and we have to obviously make sure that's representative and has the right connections. But it also overlaps with the role for lived experience, which again, we should always be asking about when we're designing pathways. And it's how we make sure that that's an appropriate joint piece of work between the Alliance and people representing lived experience. Next slide, please. This is just to show what we've actually got in terms of infrastructure. So we are in the process of recruiting our coordinator. They and the other elements will be funded 50% NHS and 50% LAs. Next slide, please. So basically, we will be having an MOU. It will be a mixture of the joint sign-off by the Alliance and the ICS of the health creation strategy, plus the extra bits about the funding. It's about building the visibility of the key roles sector has in creating health. It's about improving our links, but accepting that the Alliance is always going to be a partnership for the willing, and that, you know, we have to keep reaching out, but we can't work with people who, for whatever reason, won't work with us. It's a direction of travel. We need to get better at commissioning in an integrated way and help the sector to get the resources it needs to do what it does best. We think that this is critical to making sure the NHS doesn't try to do it all, but knows when to pull in the people who can do it better. And lastly, I think partly because of the health creation strategy having been talked about for the last 6 months or so, we've managed to get £1 million additional money for money advice this winter. So 13 CAB roles plus some other roles to make sure that we really can offer money advice to people who need it most over what's going to be a really nightmarish winter. And that's a really nice mix of winter resilience monies from the NHS, local authority monies, and it crosses a financial year. And all of that was harder to do than you might imagine, but I think it was a real success and proof of why this work is so valuable. Thank you.
So thank you for that, Tim. And again, reflecting on some of that, I can certainly see and resonate some of that in our own system. And I think it's hugely important, going back to some of your early slides, bringing it back to people and making that case that actually everything we do is about people and providing the support that they need, and it's not all medicalized, is hugely important and focuses the mind. I'm not sure you noticed, but as you were speaking, you generated a lot of chat in the chat box. So some comments in there and kind of people's thoughts and reflections, and there's also a few questions in there as well. So what I'm going to suggest is, if you could pop on and maybe answer some of those specific questions in the chat box as we move forwards. And then if there's anything else outstanding or we feel we want to discuss it a little bit further, then we'll bring that back into the panel session in just a little while. If that's okay with both of yourself. So thank you, Tim and Joe. That was really useful presentation, very valuable. And like I said, I think you've got a job to do now to ask a few questions, answer a few questions rather. Okay, so we're going to move on again. So last but not least, we're going to move across to Hampshire and the Isle of Wight, and we've got another Tim that's going to present. So if Tim and colleagues can unmute yourself and put your cameras on and take us through the next presentation, that would be fantastic.
Yeah, good afternoon, everyone. My name is Tim Cooling. I'm Head of Strategy at the Hampshire and Isle of Wight ICB and been involved with the developing our VCSE Alliance alongside colleagues who are on the call with me today from Action Hampshire. And also you'll be hearing from Peter Stokes, who's a colleague of mine from one of our local authorities, our upper tier local authorities in Hampshire. So in terms of getting into the presentation, the first slide really is to show you what our ICS looks like. And I heard someone say on a call today, actually, when you've seen one ICS, you've seen one ICS. So really it's just to highlight the fact that, next slide, please, Nick, that actually everyone's situation is totally different. People have got very different landscapes that they're operating in. And for us on this slide, we don't even have VCSE listed yet. And because in our particular patch, we've got over 10,000 organisations, 20,000 volunteers, and Google reliably informs me that if I was to put my own hexagon on that bit of paper, it'd actually be something which was called a myriagon, which has got 10,000 sides to it. So I'm busy tasking the comms team is trying to get a 10,000 sided hexagon onto that slide, just to show you some of the complexity that we're working in. So next slide, please. In terms of our journey as a system, way back in 2019, we were thinking about how we would want to work in better partnership, working alongside the VCSE. And obviously, as a CCG, we were already commissioners of the sector, had numbers of hospital to home projects, home and well projects, befriending services, navigation services. We've got lots of things going on around supporting people with homelessness and transport, and a very active and lively CVS network as well, providing infrastructure support. But as we were getting bigger as a CCG, we even back then, 2019, recognised we needed to do something different in terms of how we worked with them in a more strategic way. So next slide, please. Prompted conversations with people like Pete on the call with me today at the local authority to say, you know, we've got these strategic opportunities to work together. What can we do? How can we pool our resources and our finance and our commissioning power collectively? And then the pandemic. And we were all involved with that. We all know how the sector stepped up in terms of its welfare response, supporting the vaccination programme. And I think the sector did an amazing job in terms of showing how it can add value to the system. And I would say to colleagues that its stock has never been higher in terms of our system, in terms of visually demonstrating how it can step up and really meet the needs of the community at the time. So all of that was really great. And then of course we had the design framework come down and mandate us about working with the sector in a new way. And genuinely for those of us involved with moving to ICS from CCG, the requirement to build a new alliance with the sector was genuinely one of the more transformational things I think that the guidance has asked us to do as a system. Lots of things from CCGs have lifted and shifted into the new world, and that's great, and we needed to do that, and some of that's just quite technical. But actually, the expectation about how you work with the sector was actually something totally transformational from where I was sitting, and it was asking us to work in a brand new way, and as people have touched on already today, really addressing some of the cultural barriers that we've had about how we work with the sector, and moving from being tokenistically consulted on things to full-blown strategic partnership within a whole new health and care sector. So it's been great that we've had that ask made of us, and we've been working through that in the last year or so, and Nikki will come on to that very shortly. Alongside that, our comms and engagement team within Hampshire and the Isle of Wight, we're doing other work around working with communities differently. How do we hear the voice of our communities? How do we work with people with lived experience? And so they've been busy creating various solutions groups and holding webinars and seminars for people to get involved in terms of working with us as an organisation. And that principle that I think we'd all agree to around working with communities, not doing to communities, and actually being able to hear the voice of the patient and the public when we come to redesign our services. So we've got a strong ambition to put more strategic funding into the sector. And so as I hand over to Nikki from Action Hampshire, we deliberately took the approach of using the funding that we got centrally from NHS England to give to the sector to co-produce and properly co-produce a solution with us in the ICS, so that it wasn't a sense of us doing two, and it wasn't a couple of commissioning managers sat in a dark room coming up with a model that was then imposed on the sector. It was very much a properly co-produced piece of work, and I think demonstrating the right kind of cultural attitude in terms of how we approach working with the sector going forward. So thanks for having us today. Nikki, if you're happy, I can hand over to you. Thanks very much.
Thanks, Tim. Yes, I'm Nikki from Action Hampshire. I'm the head of VCSE support and engagement, and Action Hampshire is the Council for Voluntary Service that's been tasked with facilitating the development of HIVCA, which is the name we're giving to the Alliance. So yeah, this slide is just to show sort of the strong base we were starting from. Next slide, please. Yeah, so a lot of existing relationships and recent work that's been going on, a lot of it initiated by Hampshire County Council, really engaging the sector and working together to support communities. And HIVCA, the development of HIVCA is a real opportunity to then embed this at more strategic level. So not just about delivery, but about co-creation and strategy. So what HIVCA is going to bring about is the formal mechanism to work together at a strategic level and in terms of co-design. Next slide, please. There's a really diverse and active VCSE sector in this area already, as is shown in these findings from the biannual State of the Sector report that Action Hampshire carries out on behalf of the CVS network. So again, a really strong and active base to start from. But in order to build that trust and involve the sector fully, it needed a really transparent process of facilitating discussions. So next slide, please. This is the process so far that we've gone through, and you can find out more information on our website as well. So it was a process mainly of public information sessions for the sector and task and finish groups around things like governance, around leadership structure, representation, which looked at things like roles and processes of identifying role holders, and then the secretariat. So what staffing would the Alliance need in order to make it all function effectively? And then there was a task and finish group around positioning. So where should it be represented? For example, the ICP and the ICB. And out of this process, a business proposal was developed collaboratively, and we're at the stage now of just waiting for confirmation of approval from the ICS. So now I've got a few slides about the vision and the mission, which we'll just skate through, please. So there's our vision, just being completely embedded in creating those healthy lives. Yeah, next slide, please. And our mission, the focus on prevention and early action, creating social value, tackling inequalities, providing a direct link to communities and their experiences of health needs, and demonstrating the value of collaboration and working across and beyond organisational boundaries. Thank you. Next slide. And these are our values. So these values were all co-designed and decided in these groups and information sessions. So to be inclusive, to be strategic, to look at those wider determinants of health and bring them all to bear. Next slide, please. To be community-led, asset-based. So the voluntary sector is really good at working with people and communities in a way that recognises their whole lives and them as whole people and what they bring and what communities bring. And trust, as has already been mentioned, is so vital, not just trust with communities, but trust within the VCSE sector and trust between the VCSE and health and social care colleagues. Next slide, please. So this is the governance structure that has been designed by the VCSE in this area. So we've got the HIVCA Alliance, which is open to everyone, the HIVCA Assembly. Then we've got the place and thematic leads. So we've got place representation and thematic representation in those different areas. And these are all really vital to build that trust and yeah, have that representation from local place as well, so that they can bring their specific assets and specific challenges as well, and know that they're represented. Yeah, and then the leadership committee. And this is all supported by the Secretariat, which is the staff roles that make it all happen. So if we go to the next slide, please. So yeah, the Assembly is open to all VCSE organisations, and then people can stand for leadership and thematic representative role positions. And then next slide, please. And then we have the leadership committee. So 11 elected representatives, including a chair, deputy chair, senior representation, and it's all accountable to the HIVCA Assembly. We've got 2 thematic representative areas that are yet to be confirmed, but these have all been decided by the VCSE sector of what they felt was important. Next slide, please. And these are the HIVCA Secretariat roles and hosting that we felt was important to grease the wheels and make it all run smoothly. And they'd be hosted within the VCSE sector, Action Hampshire. And they're recruited by committee, so they're not decided upon by Action Hampshire, but recruited by committee, making sure that that whole process is open and transparent. Next slide, please. So yeah, just with all of these representatives, we need it to be a transparent process so that it builds that trust. We've agreed on the principle of rotation so that different organisations get representation at different times. Time compensated through HIVCA funding, which is just essential for providing equality of access so that different organisations, both large and small, have that capacity given to them to be able to be part of this. Training and accountability are also really important. So everyone understanding that they're not representing their own organisation, but that they're representing their theme or place. Next slide, please. I just wanted to give an example of how we feel this will work. So we're at the stage, as I said, where we've presented the business plan and we've got this these proposals that have been worked up by the VCSE sector. And we were approached by someone from the ICB around their developing digital strategy, and 2 strands in particular that they felt that they would like to work with the VCSE sector on. So one is digital inclusion and the other is around communications around their digital services. So once we have the HIVCA up and running, it will be just the ideal place to collaborate on this, both in terms of designing the strategy, what's important to people, what are the barriers and what are the solutions. Also drawing on the digital inclusion initiatives that are already happening. I've put at the bottom of this slide, recognising you're not starting with a blank page, just recognising the scope and the range of services that the voluntary sector have already set up. So drawing on those existing initiatives and resourcing and embedding best practice. So it reduces duplication and it helps put the resources where they're needed. And also the VCSE input into designing communications, because they know the people that they're working with the best, they know how the messages are going to land. So being able to co-create both sides of this strategy and work together at a strategic level, but it all relies on this open, transparent system that we've set up. So having these formal structures for selection, the clearly defined roles that have been co-designed, and having genuine compensation for time given to HIVCA means that we'll have true representation from across the sector so that everyone can input in, knowing their themes and their places the best. So that's how we're hoping it will all work. I'm going to hand over to Peter now from Hampshire County Council about some of the other opportunities that we hope HIVCA will provide.
Thank you. Yes, I'm Pete from Hampshire County Council in demand prevention, very much working with Tim and also with HIVCA and Action Hampshire about developing this. In terms of opportunity, it kind of builds on what Nikki has previously said on that last slide, really. But it's really kind of utilising. We really see the need to utilise HIVCA as a mechanism for that voluntary sector involvement and Commission strategic direction. And it's more than just having that voice around the table. It's listening to that experience, recognising what can we bring, and what the experience around that table. If HIVCA weren't there, which would be missing from that picture, and there'd be a big gap if it's not there. In terms of where that leads to is we're expecting and hoping it will lead to joint commissioning of services, and that's kind of two parts. One is in sort of joint commissioning of sort of the infrastructure around it. We've got various different groups, this sort of CVS network and HIVCA obviously being one of it, and looking at how we can expand that and also jointly align things, not only from a health perspective, but also across local authorities. What might help that also within Hampshire is a joint levelling up proposal, which has gone into the Department for Levelling Up Housing Communities, which will seek to have even greater involvement and alignment across the local authorities, which then will in turn enable this to really be a good mechanism to kind of see that joint commissioning take place. But beyond that, it's also about making sure we can jointly commission targeted prevention interventions, and that's going to help meet the needs both across health and social care. We're starting to work through that with some of our population health management work, and I think that's going to increase that, and very much even in the early stages of that, the voice of the voluntary community and social enterprise sector has been valuable to recognising what gaps were there, or equally being in those rooms and hearing, and people not being aware of what the voluntary sector provides and what they can do to kind of to work towards some of those target prevention aims. To kind of help support that is one of the things we're looking to is to streamline the evaluation framework, so that across local authorities, across the ICB, ICS structure, we can have a kind of a shared outcome alignment, which will enable not only a shared narrative and illustration, when we can also bring in data from local authorities and health to kind of support that, but it can also create a greater narrative for other senior managers within the system, as well as also helping to kind of share that narrative and that story beyond Hampshire, hopefully to attract external funding. And to kind of belie all of that, and equally building on what Nikki Anthem has said, it will kind of ensure effective communication pathways exist between local authorities, health and voluntary community sector. They are there at the moment, but they can be built, and that's exactly what this structure is aiming to do, is to solidify those and improve their efficiency and effectiveness as we move forwards. So I think we're coming to the end of our presentation. I think that's it. I think our next slide is just our details up there. So yeah, so thank you.
Yeah, thank you again, Tim, Nikki and Pete. That was again really useful, and I think just goes to show that having that a mechanism to talk to the VCSE sector and having that kind of agreed vision and mission, then leading on to the opportunities within the system is really, really important. So again, thank you for your presentation. So I'm conscious of time, so we're going to move into the panel in just a moment. As people start to collect their thoughts and start thinking of the specific questions that they want to ask Tim and colleagues, and also the previous presentations that we've had as well. Whilst people are doing that, I'm just going to come to Charlotte Owen from NHS England just to provide an update on the national support, and then we will use whatever time we've got left to answer any questions. So Charlotte, if I could ask you to jump in.
Great, thank you, Gary. Afternoon, everyone. And yes, thank you to all the speakers for their really interesting and informative presentations. They've been great. So in terms of, I'm Charlotte Owen. I work in the NHS England Voluntary Partnerships team as a Voluntary Partnerships Manager. And in terms of NHS England support, the Voluntary Partnerships team have been supporting the development of VCSE alliances since 2018 with the launch of the VCSE Leadership Programme, initially working with 2 cohorts of 19 systems in total. We have since expanded the programme to work with all 42 ICSs who were all at slightly different stages of development. And the programme is now called the Embedding the VCSE in ICSs programme. Key learning over the kind of lifetime of the work for us has been the importance of peer support and sharing learning. So we're building that into the programme as much as possible. We have regular catch-ups for system leads, lots of kind of information sessions around particular areas of priority in the peer support network, which is primarily for individuals employed in the role of embedding the sector across their system. We're looking at developing resources and tools to support the sector. We're currently doing work with the King's Fund to look at addressing barriers to embedding the VCSE within ICSs. The specific barriers they are looking at came from the independent evaluation of the VCSE Leadership Programme, and they are focusing on data and intelligence sharing, funding and sustainability, and service design and transformation. They are developing a framework based on work with systems who are doing different approaches and trialing different things, lots of interviews and roundtables. And the framework will provide a kind of range of different options that people could trial within their own system to look at different enablers for them. We're working on a quality development tool, which is based on the checklist within the ICS guidance on working with the VCSE sector, and also bringing in a lot of the insight and information from across the lifetime of this programme of work. We're bringing together case studies, example documents, and using that to kind of underpin the tool, which we are currently just refining at the moment and looking at how we align with other NHS England support offers to maximise the kind of impact and benefits of this. And we'll be starting to test that with some systems, hopefully in the kind of coming weeks. We're looking at developing, well, we should hopefully have soon, a support offer for those systems who are looking at developing their formal agreement. As Gary mentioned at the beginning, the ICS design framework highlights the expectation that there will be a formal agreement between the VCSE sector and the ICB-ICP. So systems where they require a little bit of support along that journey, we will be providing something for them to help them kind of progress. We'll be looking at some work on VCSE sector engagement and embedding within provider collaboratives and gaining even a greater understanding of where this is working, how that's been developed, and kind of the journey that's been taken to get there, and look at those different elements. And we're also just starting a piece of work around impact, looking at VCSE sector impact at the strategic level. So within the impact of those VCSE sector system level alliances, but also around different priority areas such as prevention, health inequalities, population health management. The first kind of piece of work for our provider on that is to look at gathering evidence to understand what already exists to build on that, but also to support us to develop an evidence repository, which will be available on our futures platform so that systems can use that in support of developing business cases, or if looking at expanding into new areas of work with VCSE sector within their systems, there'll hopefully be something that will help support their case and just provide a bit more evidence for them. So there's a lot going on. And I think the best way to keep in touch with what we're doing is to join our futures platform, and I will put information on how to join that in the chat box so people can do that. But yeah, that's pretty much it. That was my whistle stop tour of what we're doing. So I'll stop now. Thanks.
Thank you, Charlotte. And there is an awful lot of work going on nationally and with systems across the country. So I think there was a couple of questions in the chat box as well, just for email support. So we've got best part of 15 minutes left. We've had a couple of questions already, but it's now up to people on the call, whether you have any questions for the specific places and speakers that have presented today, or whether you've got any general questions that you would like to open up to all of the panel that we've got with us today. If people would like to raise their hands, and we will take as many as we can in the next 10-15 minutes. I thought it might go quiet at this time. Don't worry about that. I've got a question in mind, and I think I'll ask this one, and then we'll come to Andrew. So I think there was a question in the chat box around people and patients and how our systems engaging and making sure they are part and parcel, because again, ultimately the business is about supporting people in our different patches. So open to the panel, just one or two thoughts on how do we include people and our communities into all of the work that we are doing. Who would like to jump in first?
I will, Gary.
Perfect, thank you.
I think there were a couple of questions. One was about local groups and local providers feeding in to the VCFSE, and the other about people. As far as patients, don't start me off about talking about whether people are called people or patients or residents or clients, etc., but patients certainly feed in through Health Watch, and Health Watch on the committee. But we've also got a bit of funding to do some work with local groups of people. So we have been commissioned to do that, and we will be doing that in the first year. As far as providers, as I said, we're right at the beginning. We haven't even got our secretariat in place yet, but we're going to have reference groups that sit alongside the committee and then feed into the alliance. So those local smaller groups are, so for example, a mental health reference group have been set up. There will be a carers reference group, a faith reference group, etc. So hopefully we'll catch most people in that over the next year.
That's perfect, thank you. Does anybody else have anything to add on that? Again, I mean, it's similar from a Humber and North Yorkshire point of view, so I'm going to hazard a guess it'll be similar across other patches as well. I
was just going to say that the working through the alliances that you've got set up already, they're the people that are on the ground meeting people day to day, so they are the best people to go through. So but it's a good question. It needs to be a focus in part that, you know, we've included asset based in the values, so that would include, you know, getting to know people, their voice, their assets, their ideas, and it definitely needs to be brought in to the system. But the best way, in my mind, of doing that is through those organisations that are working day to day with the people.
Absolutely, thank you. So we've got 3 hands up. We're going to take those 3, and I suspect that'll probably get us to time. I've also seen a couple of questions in the chat as well, so maybe colleagues could answer those ones off in the chat. Come to you, Andrew, first, if you'd like to unmute yourself.
Yeah, thank you very much, Gary, and thank you to all the people who've made and prepared these presentations. They were really very revealing. Thank you very much. So I think this question, it particularly applies to the HIVCA presentation, but it was implicit in all the others as well. So understandably, you're putting forward these organisations as sort of channels for engagement, and I definitely see the advantage and the wisdom of that. But they consist of organisations and representatives of organisations. Do you feel that they do actually express the voice of residents? And what do residents feel about whether they're being represented in these engagements or not?
Yeah, that touches on the last question, doesn't it? Thank you, Andrew. I think that, to my mind, instead of someone parachuting in from a higher up strategy level, the best way to engage with people is through those organisations that are working with them day to day. And there's always challenges, isn't there, in engaging people genuinely. We're trying to do a bit of that through looking at peer researchers and community researchers as well. So, but it's about making that as accessible as possible for people to have their voice heard. So that won't necessarily be having a resident or person having to come to every HIVCA meeting, but it will be about ensuring that people are represented. So when there's a certain meeting around digital inclusion, for example, having people invited along from those groups, so members of those groups, and hopefully that will cover the question is, how do you engage people that aren't engaged with any groups already? And I think that, as Health Watch has been mentioned, there's those other touch points, but I think it's always going to be a challenge. It definitely needs to be high up on the agenda, and the best chance we have of truly engaging with people is as a group, because we've all got those touch points with different people, and trying to find creative ways of engaging people. So through the peer research, for example, that we're exploring, then and other ways of making it really easy for people to engage. But the people that are best suited to do that are the people working in those areas anyway. So the groups that are already working with those people and know best how to engage people with learning disability, or people that are less often heard, underserved. So yeah, that's really important work. So thank you for your question.
Absolutely, and thank you, Nikki. And before we go on to the next question, Tim, did you want to jump in on the same point?
Yeah, absolutely. I think that it's a really interesting area, and one where if you're having something that represents an ICS, it's going to be very difficult for people from small community groups or to understand what that's about and engage. So I think it is very much about how we have more local links into some of that stuff, and I think in things like the patient participation groups in primary care, which may or may not be a fantastic basis for moving forward depending on where they are and who they're connected with, but things like that are already in existence that we can build on. And I remember I had a conversation with our People First in Hertfordshire, which is a learning disability self-advocacy group, and they didn't want to be part of any more meetings. They felt they had enough meetings to go to, but they did want things like video updates and to be able to send their opinions by video into some of these meetings. And I think it's working in that more creative way and using the sector's experience in doing that as well that can really start changing the culture around some of this. It's all got to be meetings with minutes and agendas and all the rest of it, which I think is already killing some of us.
Absolutely, certainly busy diaries. We are going to get the next two questions in, but whilst I remember as well, obviously it's really important that we get your thoughts and feedback on today's session and how valuable it's been as well. So inevitably you've been invited along. There is going to be an evaluation piece, and I'm sure the link is going to drop into the chat box very soon. But if people can spend a few minutes filling in the evaluation, that would be very useful as well. Ian, I'll come to you, and then we'll come to Stuart after that.
Thanks. I'm Ian Cassidy. I'm from the North West London ICB charity sector. I'm just interested in timescales. So all of you talked around about kind of sort of the processes you're putting in place to make sure that you're really getting the breadth and depth of the sector's experience involved in this. I would say my experience so far in engagement in North West London is, yes, that works, but when you're sent a slides deck with 100 slides 18 hours before the meeting, then you can have all the structures that you want in place, but trying to then pull everyone together, that makes it difficult. So I'm just interested in your experience of managing those types of timescales, if indeed that's what you have to manage.
So who wants to answer the question on timescales? Across. I presume people obviously have all worked to timescales, and like Ian's just said, there is that value of people's time, and sending slide decks out beforehand is okay, but you need to make sure they're meaningful. So from the perspectives that we've seen, timescales, how have they hindered, helped? How have you worked alongside them to get to where you are?
Hi, Gary.
Yeah.
I'm sorry, I'm not sure I completely understood the question, which is why I've gone mute.
Sure. Sorry, maybe I should clarify. I suppose, I mean, you all talked really clearly about making sure that there was structures in place to make sure that the voluntary sector could feed in. But having those structures in place, when you're then only given 12 hours maybe to comment on, it's about how do you manage that, making sure it's still meaningful engagement.
Okay, yeah, I'm totally with you on that. I get that now. I mean, that's normal for the voluntary sector, isn't it? In every way, all year round, aside from being part of this system as well. But I think what we've done is we've kind of pushed back and said no. We've sometimes said we actually haven't got the resources to do that amount of stuff at this time, or we've said co-production's all very well, but this isn't really co-production, so let's just name that. And say we're only actually sending out a slide deck and hoping that some people send us some comments. And I think there's something for me about just being honest and transparent about what we can and can't do in timescales. We obviously know there are some things we have to stick to. But other than that, I don't think the VCFSE in Herts and West Essex is afraid of saying no. You know, with the current pressure on us and resources the way they are and etc. and everything, and my boiler being stolen from my building last night, you know, there are some things we just cannot do and we're not being paid to do. And I think that's my honest answer. Not everyone might like it.
I think that's absolutely right, to be honest. And I think my only other point in that one as well, I suppose, is how people manage meetings. From my perspective, it's about the VCSE being an equal partner, which has been mentioned a few times. And I dare say that issue of being sent a slide deck 12 hours before a meeting isn't just to the VCSE. Actually, that's to NHS colleagues and local authority colleagues, and actually everybody's in the same boat. I think there's a conversation there in terms of how to manage meetings and expectations in meetings for everybody, not just the VCSE sector.
I agree with that, and I've recently brought up also the piece that's about travelling to face-to-face meetings, which is costing the voluntary sector, well, everybody, an awful lot of money at the moment, and we cannot continue doing that. There was a question about are we paid? And you know, the funding that we've had as backfill almost will cover travel expenses issue. That's about it. So I think environment-wise, fuel-wise, everything-wise, we shouldn't be being forced to go to mandatory face-to-face meetings in order to be a part of the system.
No, and again, I agree with that. I think this hybrid model of face-to-face when it's needed and Teams and Zoom when it's appropriate is absolutely the right way to go. So I'm conscious of time. We're going to come to Stuart for the final question before wrapping up.
Thank you. I'm Stuart Lucas, and I'm basically a Mind employee that is seconded into our integrated care system here in Greater Manchester, specifically with a mental health bent. And I'm going to probably use this last 3 minutes as a bit of almost a soul sharing and a bit of a sort of process to see whether you are encountering the same issues that I do. And I think there's a couple of things I wanted to just bring up to get the panel's view on. I think the first one is the system sometimes thinks it owns all the work the VCSE does rather than just what it pays for. And I have quite a bit of problems basically pushing and saying, no, actually, the VCSE is actually doing at least 51% of what it does, you don't pay for. Therefore, you can't claim that as your own. You can only claim the stuff that you are giving us the money for. And I just wanted to see whether other people have come across that same issue. And the same with actually collecting information and collecting numbers. And I think we still end up having a real, slight sort of face-off in the fact that at the end of the day, NHS England want numbers. So to channel my inner Bob Geldof, they're after numbers. That's all they really want is the numbers. Whereas the VCSE, we're brilliant at storytelling. We're brilliant at that. And, and I've heard Claire Murdoch talk in a very, verbosely about, always about stories and understanding. But actually, at the end of the day, what they're after is the numbers. And I think this is really interesting thing about how we're actually capturing those numbers, how we're putting them across, but also how we are dealing with the fact that sometimes the system doesn't care if you're seeing 500 people once or one person 500 times. It's just the numbers that they want to basically, so they can basically put in the returns for NHS England. So I just really wanted to know whether, I'm using this as a therapy session at the end of the day, and I wanted to know whether anybody else on the call or on the panel had the same issues.
Absolutely, thank you. And you do right to raise that question. And I saw colleagues nodding. I'm going to pick on people now because I saw Jill and Matt nodding. I'm going to come to you and see if you've got a perspective on that.
Yeah, we do see that locally. We use the phrase in Gloucestershire, contribution, not attribution, which is kind of helping with the numbers game. Just feed the beast is what I say. Give the NHS England what they want. So it's this sort of column 1 and column 2 business, isn't it? We're really good at the case studies, the real people, and they want the numbers. So give them the damn numbers and let us get on with our lives. Is the kind of the way that I look at it. Jill, if you got a comment as well.
Yeah, I'll just comment about your first point, Stuart, around public sector sometimes seems to think that it owns everything the voluntary sector does, although it actually funds only a very small part of it. We've kind of got 1 or 2 stats about the proportion of the work that the public sector actually funds, and also what proportion of their spend that is, and it's tiny. So at every opportunity we kind of feed that into our presentation and just kind of continue to kind of put that back to them.
Absolutely, thank you. And I'm conscious of time. We probably could speak for days together as colleagues, but we don't have days. We've all got other jobs to go off and do as well. So I'm going to thank everybody for their time spending an hour and a half with us today. Thank you very much to our presenters for sharing the work that they're doing in their areas. I'm sure the slides will be shared, and please do spend a few minutes just to fill in the evaluation forms before you run off to probably your next meetings. Thank you very much, everyone, and see you all later.